10 a.m. So why don't we get started? Welcome everybody to this webinar set up by Patients for Patient Safety Canada. My name is Ioana Popescu. I'm a Senior Program Manager with the Canadian Patient Safety Institute, where my two primary responsibilities is to support Patients for Patient Safety Canada and to lead programs related to patient engagement. Patients for Patient Safety Canada, for those of you who are new to our webinars, is the patient-led program of the Canadian Patient Safety Institute and the Canadian arm of the World Health Organization Patients for Patient Safety Program. They are the voice of the patients. The volunteer members of our group represent patients and family members who experience unsafe care, but they are united by a commitment to make care as safe as possible, as soon as possible, by working in partnership with organizations and people at all system levels. The webinar today is developed by the Knowledge Transfer Group. Before we get started, I want to introduce you to Janet Bradshaw, my colleague here in the Edmonton office, who is our technical support. So Janet.
Hi, everybody. Sorry, I'm fighting a little bit with getting people connected, so I didn't have my camera on, but hello everyone, and I will stay in the background.
Yeah. Send her a direct if you want to connect with her. I want to welcome all of you because you are such a wonderful group of participants. We know that from the questions that you sent us in the chat box. Obviously this, not in the chat box, in the registration form. This is a topic very near and dear to your heart. No matter if you are a patient or a family member who joined us today or a healthcare provider who wants to do what's best for their patients, it's our honor to have you here on the line. The questions that you put in the registration form have been shared with the speakers today. They will try to address the questions the best way they can during the session, but what we've learned from your comments is that this is the beginning of a longer conversation. So at the end of this webinar, we have a short evaluation form that includes a question asking you to tell us what you want to see happen next, another webinar, or what would be a topic of interest. So please make sure you share that with us so we can together develop the next webinar. A few words about our technology today. All the lines are muted, and Janet will unmute the speakers at the right time. We ask you to share your experience, your questions, your comments regarding what the speakers are sharing in the chat box, or if you prefer, via email at patients@cpsi-icsp.ca. So choose your preferred method of interaction. This webinar is being recorded because we want to make it available to those who couldn't join us today. But the comments and discussion in the chat box will not be part of the recording. So feel free to type there and don't worry about typos. So with this, I will now introduce you to Teresa Malloy-Miller. Teresa is joining us today from Delaware in Ontario. She's one of the founding members of Patients for Patient Safety Canada and a patient partner since 2006. It was the tragic and preventable loss of her son, Daniel, that changed the course of Teresa's life. That unimaginable pain, combined with her never-ending passion for patient safety, resulted in many improvements, both in the organization where Daniel's incident happened, as well as at Canadian and global levels. Teresa is currently the lead of the Patients for Patient Safety Canada Knowledge Transfer Working Group and the face of many of our global webinars designed by patients for patients and providers. So please help me in welcoming Teresa.
Thank you, Ioana, and welcome to everyone joining us today. We're very excited about this topic. It's one we've been thinking about for a long time. So today we will be joined by three speakers who will speak about their diverse needs in healthcare. They'll be sharing their story and how they dealt with challenges in their care. Following their presentation, we will have a question and answer period, and we have a guest commentator in each of those question and answer periods who will add their ideas in, and as Ioana indicated, we'll be watching the chat box for your questions and comments, as well as the questions you've already sent to us. At the end, we hope to have still about 10 or 15 to 20 minutes for a general discussion of how we can empower and engage patients and families who have diverse healthcare needs to work at a system level to create change and ensure that everyone's care is safe. So we are wanting to cover an awful lot today. So we'll just get started. So our first speaker is Rob Sleep. Rob developed diabetes at age 11. His personal motto, and I love it, is just do it. This led him to a successful career in sales, marketing, and business development. In 1992, at the age of 36, he was a father of 3, and at that point he lost his sight. For 20 years now, Rob has volunteered much of his time and life experience to lobbying for improved access and equality for communities of persons with disabilities, in particular, access and independence for persons with sight loss. He is the co-founder of Access for Sight-Impaired Consumers, which is a BC-based advocacy coalition. And I'll just before Rob starts, I'm going to introduce our guest commentator who's going to join us in the question and answer period. That person will be Louis Greco. He's currently the manager of regulatory affairs with CNIB. He's held several roles in his 7 years with CNIB, including hello, welcome, Louis, who's in both Atlantic Canada and Alberta. He has a first-hand knowledge of navigating the built environment, as he has been blind all his life, and so he has much experience to offer as well. So we're going to start with Rob first for about 5 minutes, and then we'll shift to a question and answer period. So welcome, Rob, and go ahead.
Good morning, and thank you very much for that introduction, Teresa, and my thanks to everybody for this opportunity to share my journey in terms of accessing medication with a total sight loss. Just to update everybody on a few basic facts, I'm currently 63 years of age, and I've been living with a sight loss since 1992, and find each day is an adjustment in learning to live with a total sight loss. As Teresa said, I was diagnosed as a type 1 diabetic when I was 11 years old, so 52 years ago. My parents basically managed my medications during my childhood and my youth. However, when I headed off to university and suddenly realized that I needed to do that independently, it became just a daily task. It wasn't as much of a challenge as it was when I lost my sight back in 1992. When I lost my vision, I went through a number of adjustments, and thanks to the Canadian National Institute for the Blind, I learned to live with sight loss. However, it became a significant challenge when my marriage collapsed approximately a year or a year and a half later. I suddenly found myself being totally dependent on others to get through my daily routines. And I was very fortunate to have a neighbor down the street who was an emergency room nurse. She and I worked out a schedule where she would drop by every Sunday afternoon, fill my insulin syringes for the week ahead, but it wasn't the best diabetic management in the world. The difficulty being that she could only fill my syringes with a certain amount of medication, and that's not really the best way to manage your diabetes. Later on, I learned, probably 2 to 3 years later, my endocrinologist introduced me to what's known as an insulin pen. And the type 1 diabetics in the room or participating in this webinar will know exactly what I'm talking about. An insulin pen is a device where the medication comes in a glass vial measuring approximately 5 centimeters in length and maybe about 1 centimeter in diameter. I liken it much to a fountain pen where you load the vial into the insulin pen and put a short needle on the end, and you can manage your own medication independently by just dialing out the amount of medication and then injecting yourself. This was a godsend because it allowed me to now be independent in terms of managing my insulin dosages each day and taking the required amount based on my blood sugar test that I did 3 to 4 times a day. However, where the problem came in is I was taking 2 types of insulin. One is a very fast-acting type of insulin, and the other is a slow-acting insulin that releases its potential over about a 12-hour period. The difficulty is when you're living with total sight loss, you have to rely on your other 4 senses. And in the case of loading these insulin vials into your insulin pen, you have to rely totally on touch. The difficulty is the manufacturer has color-coded these insulin vials, but they've done nothing to make them tactilely identifiable. And so where the problem came in one day is I accidentally mixed up my medication, and I loaded the 2 insulin pens that I have. I loaded both of them with the fast-acting insulin. The type 1 diabetics in the room are probably going, oh my goodness, I know what's about to happen. One evening, I took my medication, a small amount of the fast-acting insulin, and I take a much larger amount of the slow-acting insulin. But of course, having mixed the vials up, I accidentally injected myself with 4 to 5 times the amount of fast-acting insulin that I should have. As a result, about 3 hours later, I found myself in the emergency ward at the local hospital. Excuse me. And we were able to determine where I had gone wrong the following day. The difficulty here was that there was no way for somebody with sight loss to identify this medication independently. And so all of a sudden, I realized that I was still dependent on the sighted community, friends, neighbors, that kind of thing to help me with my insulin dosage. To make matters a little more complicated, in 2008, I met the medical definition of crashing in to Vancouver General Hospital with acute kidney failure. And as a dialysis patient, I was now on a number of other medications to manage my loss of kidney function. Fortunately, after 6.5 years, I am now the recipient of a kidney transplant. But this complicated the situation even a little bit more in that I'm now on 13 different medications as well as my insulin dosages. And so the problem became, how do I independently and confidently manage those medications with a total sight loss? And as Teresa said in the introduction, I was the chair of an organization called Access for Sight Impaired Consumers. We were doing some work in terms of helping our community independently identify medications. And now all of a sudden it became a very personal issue for me. And so what we did is we looked at a number of different devices that were available out there, and we came across one product out of the US that enabled a pharmacist to label the prescriptions with something other than just a print label, because obviously the print label was of no value to me whatsoever. And so this device enables the pharmacist to encode an RFID label on the bottom of the prescription bottle, and with the addition of another device or an app on my iPhone, I can now independently and accurately identify these medications. The interesting thing through all of this is, as we were looking at making these medications accessible, we had to keep in mind that individuals who are blind are not necessarily blind to the extent I am. I have no light perception whatsoever. I cannot identify colors, and so it makes life a little bit more challenging. But we also had to recognize that there were individuals out there that spoke languages other than English, so we wanted to make sure that French-speaking Canadians could access their prescription medications. And we found through this organization in the US, a company called Envision America, that pharmacists were able to label their prescriptions in languages other than just English. The main difficulty, though, was finding a pharmacy or a pharmacy chain that would take on the additional task of labeling these prescriptions. And we were successful in doing that. Unfortunately, it came to a human rights complaint against 2 national pharmacy chains. But now in British Columbia, we have, last count, I think we have 10 pharmacy chains that will now provide their prescriptions to people who are blind or partially sighted in an accessible format. So recognizing that time is limited, I'll perhaps stop there and maybe turn it back to Teresa and see where we want to go from here.
Great. Thank you, Rob, for that great description. I think we'll go right away to Louis and ask for a comment. Louis, would you like to add to what Rob has said?
Yes, I think Rob's story, although people with total blindness or total sight loss do represent a very small percentage of the people that CNIB works with, that really doesn't matter because the story is the same. When people acquire sight loss later in life, and then they acquire other ailments, they may be bombarded with a host of medications. So whose responsibility is it to make sure that the patient really understands how to take their medications, when to take it, what the side effects are, and all of the other details that go with managing a chronic condition. The bad news is that it's going to get progressively worse as society continues to age, as modern medical science comes up with new and innovative ways to extend life, and the optimum solution for everyone, let's face it, is to support people living in their home as long as they possibly can. A CNIB goes in and let's call it MacGyvering. I'm not sure. Hopefully everyone's familiar with that term. We go in and we'll have our independent living specialists work with people to try and come up with strategies on how to manage a multitude of medications. Our blister packs the panacea? No, they're not. You miss one dose for whatever reason. How do you know? How can you find out what mitigation steps you need to take? Is it a serious issue? Is it something that you can disregard and get back on stream very quickly? That information is not available. Every prescription issued in this country, and probably around the world, comes with a product monograph. I don't know how many people listening today actually read those things, but you have the choice as to whether or not you read them. For someone with sight loss, understanding what's being prescribed to them isn't readily available. Yes, pharmacists do the best they can, but when you're standing at a counter and they say, take this at 2 o'clock, take this without water, and they may tie elastics around the pills or find some other quick and easy way of identifying the pills, you walk home and your head's spinning. So the solution that we're looking for is that the information that every patient receives when they're prescribed medications or even over-the-counter medications, that all the information that's available in print is available in a format that's acceptable to them. Whether they choose to access it or not is no different than the general population. I'm pretty sure that there's some regulatory requirement that says, Mr. Pharmacist or Miss Pharmaceutical Company, you must provide key information for people to read. But they don't go far enough, and they don't say you must provide it in a format that's accessible to people with sight loss, who may not be able to comprehend, so people with print disabilities, and as Rob said, people with language barriers. I'll wrap up really quickly because I know time is of the essence. Look at oxygen dispensers. How would someone who's blind be able to to use an oxygen canister if they have no idea what's left. Alberta, several years ago, introduced a new at-home heart monitoring program, and in my role with CNIB, I phoned them up and I said, is this usable by someone who's blind? And we had silence, and they said, no, it's not. We've never thought about that. So my message, and I'm pretty sure Rob will concur, is as dialogue continues with regulators, with manufacturers, with professional associations, the need of diverse populations like people with sight loss, you can't keep disregarding it and hope that at the end of the day they'll be okay, because as Rob's story illustrates, they're not. So thank you for the opportunity. I apologize for my raspy voice. I'm really sick today, so I'll stop talking now.
Great. Thank you, Louis, and thank you, Rob. You've started us off with wonderful description of the level of the problem and some directions to go. So I think, considering time, we'll move on to our next pair of speakers. So this next section, and Louis has kind of given us that segue, is we'll be looking at language barriers as a safety barrier. And our speaker is Bernie Weinstein. He's a member of Patients for Patient Safety Canada, a well-loved member. He's part of the Speakers Bureau, and he's part of the Knowledge Transfer Group as well. He was born and raised in Montreal. He's a die-hard Canadians fan. He's had a 33-year career at CN. He was an engineer, and he retired as the Director of Corporate and Economic Strategic Planning. He's very actively involved at the Jewish General Hospital as a patient advocate. He sits on the Quality and Risk Management Committee, and I think many, many others. He has a very full life with his wife and his children and his grandchildren, and he's just a very fun person. So Bernie is going to be our speaker, and in the question and answer period, another member of Patients for Patient Safety Canada, Esha Ray Chaudhuri, will be joining us. Again, she's a member of Patients for Patient Safety Canada. She has a passion for patient safety and a very extensive professional expertise concerning many Canadian and global initiatives. I think she's worked around the world. She's very humble, but Esha really was the force that kept pushing us to do this webinar. So we're delighted to have both of them with us today. So Bernie, I'll hand this over to you, and then we'll get to the question and answer period. Go ahead, Bernie. Do we have Bernie?
We're having problems with Bernie. I think he's a call-in user, and I haven't been able to identify him. So I'm not sure if the best option is for him to hang up, and I can call him back.
Okay. Then you know what, I think what we'll do is we are going to come back to Bernie and Esha, but let's go ahead to our third group. They're now number 2. And we are the next pair of presenters are going to be bringing us to consider people from First Nations communities and their diverse and very important healthcare needs. Our speaker is Samara, Nancy Cardinal. She is also a member of Patients for Patient Safety Canada. We're delighted she's joined us. She's currently a student at Mount Royal University. She's the owner of a holistic healing business, and she works as a medical cannabis educator and consultant. She's a very proud member of the Métis of Cree and Canine Heritage. And then in the question answer period after Samario will present, Tilak Tenakoni will be joining us. He has many years of experience and has received many awards for his work in the areas of diversity and inclusion. Over the past 19 years, Tilak has worked as a diversity consultant with the Public Service Commission in Prince Edward Island. He's also the chair of the Diversity and Inclusion Committee of the town of Stratford. He's a member of the Canadian Commission for UNESCO Advisory Committee on Municipalities Against Racism and Discrimination. So we're delighted to have them. So we will start with Samaria. So welcome, and I'll hand it over to you, Samaria.
Thank you very much. I'm honored to be part of this webinar. Thank you very much for inviting me. I just wanted to give a little bit about my history. I am a Métis of Kainai and Cree heritage, and my father was in a residential school. As a result, people in residential schools, they developed quite a few problems. One of them was very much of a lack of parenting skills, anger, and a number of other mental health issues. This was transferred to me, and there's a lot of research being done right now on historical and intergenerational trauma with regards to Aboriginal people, and it is a real problem. With myself, I was diagnosed so many conditions. They were all incorrect. When I was younger, I went through 5 years of shock treatment, and I was on at one point 15 different medications. I basically sat on the couch and drooled. I was put on AISH. I had to take access around Calgary because I could not even drive. My driver's license was taken away from me. And at one point, they were going to lock me up in a place called Michener Center because they didn't think they could help me. Every time I would go see somebody, it was just take another pill, increase another pill, take another pill. And nobody was helping me. They were just funneling me back and forth. And I was depressed. I was suicidal. I didn't know where to turn. My life was falling apart, and I was grasping and reaching out, and there was no one that could help me. Finally, one day, it was basically, I was at the point where I might as well kill myself because this is not an existence. This isn't life. And so I thought about it a while, and I was like, these people are not helping me. Nothing is helping me. And I went into the hospital, and I fired my whole medical team. And they were very upset with me for firing me, and actually security walked me out of the hospital. And since that day, I have become empowered. I have taken control of my own life. I am no longer on any of those medications. I've gone back to my traditional ways, and I have been fine. I have no problems whatsoever, and I know what my problem is. I had intergenerational trauma, and it is something that I'm working on with traditional elders on healing myself with. And since it's been passed to me, I now talk to my daughter about it because she will be also affected. And I'm hoping that it will be decreased. Her symptomology will be decreased from what I experienced, and then down the line to my grandson. But this is a real issue, and the general public needs to hear about this. And you see all these Indigenous people on the streets with alcohol problems, with substance abuse problems, homeless. They are suffering from intergenerational trauma. And when we start dealing with it in an appropriate way, then these people will be able to seek help, and the medical, the medical community will be able to help them more when they become more informed of the problems that are being experienced by the community. So thank you very much.
Thank you, Samaria, for that description. So now I will call on Tilak, if you would like to comment first, and then we're going to open it up to questions. Tilak, would you like to go ahead?
Thank you very much. I am joining from Prince Edward Island. Although I am not an expert on Indigenous issues or Indigenous, the lifestyles. I myself being an immigrant to Canada, also having experience working with public service for almost 20 years, one of my areas is to develop cultural understanding and cultural competency. It is pretty much the same thing that I heard over the last few years what Samaria was saying. First of all, my personal opinion is health professionals or medical professionals or health authorities have to have some comprehensive understanding about this intergenerational trauma. We do know that Truth and Reconciliation Commission report made a number of recommendations and developed an action plan. So it is all about understanding, comprehensively understanding about this intergenerational trauma and some complexities experienced by our indigenous members and indigenous community. We all know the healing process is different than mainstream community interpret, it is a very comprehensive and complex process within our indigenous communities. So it is not simply the individual, it is associated with individual, family, and community. So the healing process also has a different definition and interpretation given by our indigenous communities. So health and medical professionals, healthcare authorities, staff have to have this increased understanding about this unique cultural aspect. I can share with you my own experience. We work with indigenous organizations, communities, and key members, elders from our own community. We invite them, we ask them to come and talk about their culture, their lifestyles, customs, and traditions with our members. We also work with organizations representing Mi'kmaq, Aboriginal, and indigenous communities. One of the areas that I would like to see happening in future, having more staff members working with healthcare system that represents our indigenous communities. Say, for example, having more nurses, having more home care support workers, or having some resident care workers or some other kind of health professionals within health system, so that we would have better understanding about the great need and unique needs of our indigenous communities. It is also important us to work very collaboratively. This is not simply healthcare professionals. We have to work with education institutions, academic institutions, as well as community organizations, government organizations, both levels, plus municipal governments, developing new programs to support indigenous communities, understand their needs, understand their unique situations. So these are some of the strategies I can think of knowing this situation. Most importantly, it is very instrumental having better understanding or increased understanding about our indigenous culture, their history, tradition, and some of very important aspects of their lifestyles. I think that is my first comment. Knowing the time, I would like to pass to the commentary.
Okay, thank you, Tilak.
Thank you.
We have just a minute, and I think, Samaria, I wondered if you could comment a bit more in your journey. Is there some particular things that you found really help people from your community when they have healthcare needs? Is there some particular strategies that you found to be really helpful? You certainly described just coming back traditional ways, but are there additional things you might like to highlight at this time?
I think just it's really important for Indigenous people to feel comfortable in when they're going to seek help. There is so many misconceptions and judgments going on by the dominant culture in Canada of Aboriginal people that it's causing a lot of problems. A lot of people won't even go seek treatment or seek help because of the judgment and the myths that are predominantly carried by so many people. And it just is going to take time for people to start understanding our culture and understanding our ways, because it's been totally put under the rug of our culture, and the myths and the misconceptions that are out there. Nobody is doing anything to stop them or to educate the public. All these, new people coming into the country, they come in with all these myths that they're being told by other people about us, and I constantly hear it every day. People coming up to me, oh, well, you don't pay any taxes. Well, I've always paid taxes my whole life. I don't get anything free. I am just like any other Canadian citizen. And also, Indigenous people actually drink less alcohol than the regular population. So no, we're not all a bunch of drunks.
Yeah, thank you for that, Samaria. There's so much we have to learn. And I think we will come back to this in our general discussion at the end. But just looking at our time, I think we will move on. Iona, have we found Bernie?
Yes.
Okay, so I think we'll go back to our final group of speakers, Bernie Weinstein, who's going to talk to us about language barriers, and we will come back to a general discussion. So go ahead, Bernie.
Bonjour, je suis Bernie Weinstein et je suis à Montréal aujourd'hui. Je suis une représentative des patients à l'hôpital général juif. I did this in French to see how many of us understand French and how many of us could give an informed consent to a clinical procedure in a language that, well, you speak but not really. I was born in Quebec. My mother tongue is neither English nor French. I learned how to speak French in Montreal, going to school, but more importantly, while working. I'm the child of immigrant parents, and I can tell you that I went to a school where we learned how to speak 4 different languages. Unfortunately, the only language that I use effectively, and I am rated by the federal government as being officially bilingual, but the only language I use effectively is English. This is a country of immigrants, and we continue to bring more and more immigrants into this country. We speak hundreds of languages and dialects, and we cannot, never, expect all clinicians to understand and speak all of these languages. In Quebec, there are about 1 million to 1.5 million people we lovingly call Anglophones, those people who speak English as their primary language. There's about another 1 million to 1.5 million allophones, those people who do not speak English or French as their primary language. And there's about 5 million francophones. The problem is many doctors speak both English and French. Very few doctors speak all of the other languages that are important, that other people speak. At the Jewish General Hospital several years ago, they conducted a survey, and what they found is pretty interesting. They did a survey of 1,000 patients in the emergency, several wards, and several clinics. These patients originated from over 110 countries and spoke 90 languages. 7% of the people that they surveyed, and there were about 1,000 patients surveyed, could not communicate at all in English or French. 25% felt they didn't have enough English or French proficiency to communicate efficiently with healthcare providers. And 1/3 of the people surveyed said they would rather be communicated with in their own language, not in English and not in French. Obviously, this is untenable. I mean, how do we manage this within the context of an institution or even your own doctor's office, where at best I would think most doctors, most clinicians can only speak 1 or 2 languages. I have a couple of suggestions that we've used at the hospital and I'm sure are usable almost everywhere. First of all, as we've long maintained, every patient needs an advocate. Every patient who goes to see a medical practitioner should have someone with them to help them understand. When patients go to see a doctor, they're coming in pain, they're afraid of what the doctor will discover, what the cure is, and they need someone there to be a little more objective. In many cases, what the person may bring with them, especially if they're not comfortable in English or French, speaks the other language. However, this can offer many problems. First of all, you have the issue of culture. I can remember going to the doctor with my mother, who could speak English but not very well, and having to sit through while my mother was examined. I can tell you, that's not very comfortable. There's the issue of confidentiality. I'm not sure every patient wants to share with their best friend what their problem is. There's the issue of conflict of interest. And of course, the real problem is that most of these family members are not clinicians and therefore don't fully understand what the patient is saying and what the doctor or the technician is saying. And I think that in itself is the biggest patient safety issue, that you could have someone misinterpreting what is being said. At the Jewish General Hospital, we have approximately 250 people who have signed up with the hospital that they can speak a language other than English or French. In total, this covers about 60 languages. However, if you remember, I said we had patients who spoke as many as 90 languages. There's another hospital that I went to recently that had a sign in the front entrance listing all of the languages that were spoken in the hospital and asking, if you speak a language other than this, please advise us so that we can make use of you. Many hospitals, especially in Quebec, have trained staff who speak languages other than English and French. The most important thing that I can suggest to any patient who is not 100% proficient in both English and French is that they speak to their clinician, either the clinician themselves or the secretary or whoever makes the appointment, and advise them that they speak a language other than English and French and that they would appreciate translation services. Some hospitals have formal agreements with services that provide these translation services for patients. And I think it's important that when a patient isn't comfortable in the language that is commonly spoken, they use these services. Thank you very much.
Thank you, Bernie. And now I think, Esha, would you like to comment at this point?
Sure. Can you help me? Can you hear me?
Yes.
Oh, wonderful. Okay.
Ahead,
all right. This is Esha Ray Chowdhury from Calgary. Actually, I'm feeling conflicted here. All the presentations so far have been so wonderful that I have so many things that I would like to ask or to comment on, but in any case, I'll just stick to my comments for the webinar and then get into the general discussion. I sincerely thank the Patients for Patient Safety Canada for providing me this opportunity for participation in this unique webinar of the patients, for the patients, and by the patients. I also thank all the participants of the event. Now, it may be interesting to note that even though I have been assigned to comment on Bernie Weinstein's presentation focusing on critical challenges of language barriers in patient safety, it is my belief that implications of his negative experience go much further. In fact, all the presentations so far that I have heard reveal the serious fractures between the inclusive purpose of our health policies and real-life inequities that our patients are very often, the diverse patients are experiencing, just failing to access and utilize the appropriate health services that may be available to others who are not identified as diversity. At this time, I would like to take a detour saying that even though inequities suffered by the linguistically handicapped patients may appear to have no obvious relation to safety issues in engineering industries, I believe that our discussion today dealing with the role and function of diversities in health systems do. It has to do with engineering principles of the systems approach, where every engineer knows that unless well connected as a whole, diverse parts by themselves cannot improve the system. My comments on linguistic diversity are framed within this systemic lens. Systemically, patient experiences related to risks of harm from barriers of linguistic, cultural, and even physical concerns are viewed as connected parts of a chasm that the Institute of Medicine talks about, continuing to impede our equitable vision of making every patient safe. Systemic strategies to improve patient safety for culturally and linguistically diverse patients are directed at multiple levels of health systems, given the role of patients, providers, organizations, and policies in shaping the quality of our patient safety. At the organizational level, interventions can include a variety of plans as part of a comprehensive multi-level strategy, such as the culturally and linguistically appropriate services, or CLAS, C-L-A-S, developed by the AHRQ, or the Agency for Healthcare Research and Quality, which is also a blueprint for national equity standards and outcome-focused practices. Some other recommendations, like the excellent suggestions by all the earlier speakers, for advancing and sustaining equity initiatives include clinical guidelines, financial incentives, community engagement, patient-provider relationship, and interpreter services that Barney talked about so brilliantly. The Institute of Medicine's report on unequal treatment recommends critical need for standardized training of linguistically and culturally competent translators and interpreters who understand cultural context of language to represent patients who are linguistically diverse. Finally, in terms of patient safety, a systems approach makes us aware that safety of the linguistically diverse or in any other diversity patients depend not only on their language proficiency or compliance with conventional norms of culture-specific safety obligations, like Nancy was talking about, but on our collective ongoing learning about the many upstream factors that make some patients different, socially and individually, helping us to know the whole person, no matter how different she may be physically, linguistically, or even in terms of her values and beliefs. This is especially true when making every patient safe remains our ultimate goal. Thank you.
Thank you, Esha. You've very skillfully taken us to that system level. We now have time, and we're going to just open it up to a general discussion. And Iona, before I go back to the speakers, do you have, are there any pressing questions from our chat box that we would address first and have our speakers address?
There isn't anything pressing in the chat box, so I would suggest, yeah, open it up to the speakers so we can have a bit of a conversation among each other.
Okay. So I think we'll, if we go to that, there's that general need to get more diversity at many different levels in our healthcare system. And I think what we'll do is just go back through our speakers and address that question. So if you could all, and we'll just kind of take a minute each. So the question would be, how do we get more diverse representation on quality councils in the hospitals, on community committees, on patient family advisory councils in hospitals? How do we get that voice forward? So maybe we'll just start at the top. And Rob, do you want to go first? Ideas of, are there particular ways that are going to help us to get more an inclusive voice in healthcare? It's a big question. Do we have Rob there? Iona, have we lost Rob?
I don't think so. Rob, just try to unmute your line. You're there.
Okay. We'll come back. I know we will find Rob again. Louis, would you like to, what's your understanding of how we could get more diverse voices at more of a system level in the healthcare system?
The strategy that we promote within the various arenas that we try to influence is to have or to ensure that the perspective, the lived perspective of people with sight loss or other disabilities is incorporated into the decision making. How can policymakers and administrators really implement programs that are inclusive of people with disabilities, and particularly sight loss, if quite honestly they have no idea what the challenges faced by people with sight loss are? It never ceases to shock me when I visit a hospital or a clinic or what have you, and the medical personnel really are as uninformed as the general public. Now, I don't know why that shocks me, but one would think, or one would hope, that people working in healthcare, both at an administrative and a clinical level, would at least have some sensitivity and understanding of the diverse challenges and the strengths and opportunities of the people with disabilities can bring. So my short answer to that question is people need to be at the table. Conversations like this are a good first step, but policies that affect people cannot be developed in isolation of people that they're intended to benefit.
Great, thank you for that, Louis. Do we have Rob's line open yet?
Yes, my apologies. I'm sorry. I was having some difficulty with my mute switch here, but I have to agree with Louis 100%. What I find, and this was particularly interesting when I was going through all my eye surgeries and so on and so forth. I think back to when I was in my ophthalmologist's office and then in my retinologist's office. Their manner in terms of helping me just down to the examining room was unbelievable. And I think back not only to their lack of understanding of the patients that they're dealing with, which really surprised me, but I also want to maybe share with the group an experience I had with Vancouver Taxi Association. They came to a pan-disability group and said, we need to understand better how to serve people with disabilities. And I was invited to the table to share my perspective in developing a training program, which we eventually called ALA. It stands for Ask, Listen, and Act. Because a lot of people think they know how to help somebody who's blind or partially sighted, but what we really wanted to impress upon the Taxi Association and their drivers is ask how best you can assist us, listen to what we have to say, and then act accordingly. Don't just assume you can reach out, grab somebody by the arm, and pull them over to your cab. So that's just a very small example, but I think Louis put it very well. You really need to include the people that you're trying to assist here.
Great. Thank you for that example. That's wonderful. Samaria, would you like to add, could you add to this conversation now in terms of how do we get Indigenous members, Indigenous voices into that system level conversation about healthcare?
It's really important for the Indigenous community to educate the rest of Canadian society. And it's important for the regular Canadian society to start learning about our culture. We are not one homogeneous culture either. That we are a very diverse community with many different languages and ways. And I feel it's really important for the medical community to start realizing that we had our own systems of healing, which were used for thousands and thousands of years. And our systems of healing were going fine before colonialization took effect. So with regards to the medical community, they need to start putting in aspects of Indigenous culture and healing into the medical community and start using elders from the community. They should be having training with regards to learning our practices and what we go through as individuals. I think that would really open eyes up and to make people more understanding of what we've been through as a people.
Great, thank you for that. Tilak, can I ask you for just a very brief comment? What would you say in terms of getting diverse voices up?
Listening to Louis, Rob, and Samaria, my brief response is, first of all, that it's true that we have to have policies, practices, programs, and support systems in place, identifying this diversity of needs of our clients, of patients. Okay. Another step would be developing some guidelines for staff, having some training on diversity, inclusion, and cultural understanding. Especially, as Samaria mentioned, the training programs on Aboriginal, Indigenous, or Mi'kmaq communities, their history, their tradition, and the customs and lifestyles. We certainly have to have more training programs incorporated into HR plans on cultural diversity, different cultures, different community groups, and different aspects of diversity of cultures. It is also a good idea to work with local organizations or regional or national organizations that represent this diversity of communities. This may include immigrant serving agencies, ethno-cultural groups, academic institutions, or any other church groups or any other organizations that work for diverse communities. It could be linguistic diversity, it could be cultural diversity, or it could be generational or any other type of diversity. Having comprehensive and the meaningful programs to respect, value, and acknowledge these different diversity dimensions are equally important. Staff, medical professionals, health authorities have to have better understanding of the needs of diversity of our clients.
Thank you. This is such an important topic. I think we've just barely scratched the surface. We have run out of time, and so Esha and Bernie will just have to hold your comments. I thank everyone for your great insights. We have much work to do in understanding and bringing these diverse voices forward. So thank you, and I'm going to hand this over to Iona for just a final comment.
Yes, a big thank you to all of our speakers and especially you, our participants. I believe you have already completed the evaluation poll that Janet has put on the screen for you, so thank you for that. If not, we will send you the slides with a little note and a way to contact us very soon, as soon as they are available. so we can stay in touch. And again, we welcome your ideas on what do you think we should do next? How can we explore this diversity topic? When Canada celebrated 150 years, diversity's strength was our logo. And I do believe in it. I'm a dual citizen. I'm Romanian and Canadian, and it really resonated with me. But we heard today that we are not doing enough. Diversity is not yet our strength. So let's work together to make it happen. A big thank you to Teresa and every one of you, and I wish you a wonderful